had mentioned earlier about barriers to topical steroids. Can you go into some of that?
Yeah, so I find, and this isn't exclusive to rheumatologists, this is all kind of non-dermatology providers. I find that, and this is true for all healthcare providers in general, if something is a little out of your wheelhouse, you often have things about prescribing you're either hesitant to prescribe or you incorrectly prescribe in some way. Because you're not sure about what the exact side effects are or how you should be appropriately using a medication. And so that comes into play a lot with topical steroids. And again, not just for rheumatologists, but for any kind of primary care provider as well who might be prescribing them. And so one issue I find is that I'll be addressing is just picking an appropriate strength of the topical steroid. And so when you're deciding what strength I like to categorize into very low potency, moderate potency, and strong topical steroids. And we basically decide which class we want to use depending on the location that we're treating and also depending on the disease process that we're treating. So the strength is one important component. And oftentimes non-dermatologists undershoot with strength because they're anxious. They don't want to treat with something too strong because they're worried they might do damage, which I think is a good caution to have if you haven't been kind of coached on how to do it appropriately. We also talk about using the appropriate vehicle. So things like, what is the steroid impregnated in? Is it a solution, which is more alcohol based? Is it a cream, which has some water content, but is a little bit thicker and more moisturizing? Or is it an ointment, which is like a sticky, greasy base? And that's important for several reasons. One is because it affects the potency of the topical steroid, but also important because if your patient hates the thing you prescribe to them, they're not likely to use it. And so if you're, especially like, for instance, if a rheumatologist is treating scalp psoriasis, if they prescribe an ointment, the patient's never going to put a greasy ointment in their scalp. But if they prescribe a solution, an alcohol-based formulation that you wouldn't want to prescribe for the body necessarily because it would be drying and irritating, but it's perfect to apply within a hair-bearing area, then the patient is likely to use it and likely to gain some benefit from it. And then the last thing is the quantity of steroid prescribed that we talk about. And so if patients have a very high body surface area of psoriasis, and let's say you've decided to start a biologic, but you're waiting for that biologic to take effect and the patient is very uncomfortable. If you prescribe a tiny tube of hydrocortisone, again, low strength and also low amount, the patient will have one application to one arm and that will be the end of the story. And then of course they'll report the next time they come in, that cream did nothing. Well, truly the cream is probably not the issue. It's the amount and the volume of the cream that they have. And so I also try to just encourage people to make sure they're prescribing adequate volume so people can appropriately apply the steroid.